Hi, I'd like to record a lecture on the pain chapter, which is Iggy, chapter 3. Starts in the 8th edition of Iggy on page 24. Pain is something that you guys probably know, obviously, some about as you're coming into this chapter. Pay attention to all the blue bold terms. And there are several pink and yellow boxes that will get you through this chapter to help highlight your reading. So acute pain, short duration, usually we think of some type of surgical pain, musculoskeletal pain, chronic pain greater than 3 months, may not have a well-defined cause, may start out gradually, maybe from mild to severe. Nociceptive pain, this is normal pain processing where it is, we talk about the gate control theory. Neuropathic pain is abnormal pain processing, usually abnormal pain processing as in peripheral or central nervous system issues. And then we have breakthrough pain. Just some other definitions here for you to look at. Perception, threshold, and tolerance. Dependency, drug tolerance, addiction, and pseudo-addiction. So you can look through those. So pain is very universal. It's complex. Each person has their own personal experience. As I mentioned in class, pain can be considered the fifth vital sign. Pain can be defined as whatever the experiencing person says it is and exists whenever he or she says it exists. A lot of times pain is inadequately treated in all healthcare facilities. Number one reason to seek medical treatment. Pain is the number one reason why we take medicine. And it can really diminish a person's quality of life. When we talk about people that are inadequately treated for pain, a lot of times it's older adults, substance abusers, because we have our own thoughts on what we think someone is or is not in pain, and those that maybe have a language barrier, culture barrier. Here's some facts. 1 in 4 Americans suffer from pain. Pain affects more Americans than diabetes. Chronic pain is the number one cause for long-term disability, and there is a box that talks about somewhere that talks about women have twice as many pain receptors as men. Somewhere in the chapter. Can't find it. As our role, we are the patient advocate. The nurse has a legal and ethical responsibility to ensure the patient has adequate pain control. So how often a shift should you be checking for pain if the patient doesn't display any? You should be checking every 4 hours for pain, doing a pain assessment. So if that's a 12-hour shift, you're doing it at least 3 times on your shift. And that's if someone has no pain. If they have pain, obviously we are treating them. We're treating them pre-procedure sometimes. We're treating them post-operatively. And we are also following up with anything we do for pain, whether it be pharmacological or non-pharmacological. The Joint Commission says all patients have the right to effective pain control. Reassessments usually take place in the form of what we did for the pain. So if it's an IV push pain medicine, we should reassess in 15 minutes. If it's an oral pain medicine, 45 minutes to an hour. If it is a non-pharmacological intervention, usually that requires a follow-up in 15 minutes. We want to give good patient and caregiver education and communication. So this can really not be delegated to an unlicensed assisted personnel. Untreated pain can cause anxiety, fear, chronic pain syndrome, depression. Freak pain facts, you can read through those on your own. here's our definition. Again, acute. And then chronic is broke down into cancer and non-cancer pain. Non-cancer chronic pain can take the form of Crohn's disease, interstitial cystitis, rheumatoid arthritis, diabetes, fibromyalgia, those types of pain syndromes. And then we want to make sure that you look at table 3-2. What that is just a breakdown of the difference between acute and chronic pain and some of the characteristics involved in each one of those. So the physiology of pain, this came out of the ATI book. It is also in your textbook on pages 26 and into 27. So we have transduction, which is converting the painful stimulus to an electrical impulse that travels up the peripheral nervous system, nociceptors. Then we have transmission, occurs as the electrical impulse travels along the nerve fibers, where neurotransmitters can regulate it. And this is where they talk about in your book the A delta, C delta fibers. And then the pain threshold is the point at which the person actually feels it. And then this is your conscious awareness of pain. And then pain tolerance, the amount of pain that you can handle. Substances that increase pain transmission are these 4 substances listed here: prostaglandins, bradykinin, histamine, substance P. And then there are 2 substances listed that decrease pain. Modulation, afferent input generated in response to noxious stimuli, happens at every level from the peripheral to the cortex. Actually occurring in the spinal cord. This is more or less your pathophysiology of your nociceptive pain, or your normal pain processing. Here is a visual picture of the gate control theory, which is also in your textbook. Then we have abnormal pain processing, which is called neuropathic pain. We don't know a lot about, much is unknown about neuropathic pain. Usually it's driven by damage to or dysfunction of the peripheral and or the central nervous system. It's very hard to treat. Some of the subjective words the patient will use to describe this pain are burning, shooting, stabbing. This usually isn't treated easily with just your basic opioid analgesics. You may need a drug like Neurontin to treat neuropathic pain. Back to nociceptive pain, it's going to be your basic throbbing, aching, cramping, sharp pain. The types of pain listed there are bones, organs, skin, and subcu. It can be broken down into somatic or visceral or cutaneous. And then we have, we move right along into the pain assessment. So self-report is the gold standard. So if someone is even intubated and they can point to a board, or they can give you numbers on a hand, on their fingers, we let them self-report. That is the gold standard. We need to be non-judgmental. We need to be advocates for our patients. We need to promptly relieve pain, respect patients' preferences and values. We need to be able to assess verbal and nonverbal expressions of pain. So when we talk about a pain assessment, we can get into the components of a comprehensive pain assessment. I know in a slide here or two we will cover the portion of the Johnny Logan care plan that you use to do a pain assessment with. So we want to address the location. If the patient says they hurt all over, then you have them point to the areas that maybe do not hurt. Maybe if they could mark it on a diagram or a picture of a body, that might help you to identify a location. Also to decide whether it is projected, referred, or radiating type pain if you are assessing pain location. Intensity, that is usually rated on a, if we can, on a scale of some type, and we usually give that a number. So we use a basic number rating scale, 0 to 10, 0 no pain, 10 worst pain possible. We use a FACES scale or a Wong-Baker FACES scale, and that's used sometimes for a pediatric population or some forms of patients that are maybe developmentally delayed. A verbal descriptor scale, which I've never used, and then a FLAC scale. And the FLAC scale is not in your book. FLAC actually stands for Faces, Legs, Activity, Crying, and Consolability. I think I might have it on a future slide. Moving right along, another component of the comprehensive pain assessment would be a quality. You're going to ask or describe how the pain feels. Avoid giving the person descriptive words. Have them use their own descriptors to describe the pain. Next slide, continuing on, we already covered quality. So onset and duration, constant or intermittent can be covered under there. Aggravating or relieving factors, so what makes it worse, what makes it better, and the effect on their function and quality of life. Comfort, function, outcomes. So with this one, you want to set a goal. So sometimes you'll tell a surgical patient to set a goal of a realistic goal of what pain you can live with, and a lot of times it's some number between 1 and 4. And then other information like maybe culture, past pain experiences, and medical history, that type of thing. So here again is the number rating scale. We have the FLAC scale. This is kind of a funny cartoon FLAC scale. Here is the, I should say, a funny pain rating scale, which is their eyeballs are bleeding out. So here's the FLAC scale as faces, legs, activity, crying, and consolability. This is the scale we use at SIH to assess for not pain in nonverbal patients. So maybe you're in-stage Alzheimer's patient or someone with severe MR that cannot, developmentally delayed, that cannot express pain. We may use these other activities to pick up on pain. Your book warns that a score obtained from these behavioral assessment tools is not the same as self-report. So make sure if they can that they self-report. There are 2 other scales listed. A checklist for nonverbal pain indicators and a pain assessment in advanced dementia. They are in the 8th edition on page 34, and I have never used those scales. I think we mentioned those in a minute. So here's your PQRST and U that you should be using when you do your care plan in the clinical setting. And I know some of you are getting ready to finish clinical, so hopefully you've been using this appropriately when you assess pain with your patients. Cultural pain portrait, some common cultures that are stoic, and we have trouble, because pain is what they say it is, getting these people sometimes to take any kind of medicine at all. So Japanese, Chinese will not voice pain, Northern European, and then common cultures that are very emotional with pain, Hispanic, Middle Eastern, and Mediterranean. So they're we kind of know clusters of information that are with each culture, but every single individual person is different. The pain hierarchy, this is in a purple table on page 33, and it just talks about to use when self-report is challenging. So we try to guess which procedures are known to cause pain, and we may want to assume pain and give medication for that. So for instance, if someone is intubated and on a ventilator, critically ill trauma patient, we assume that they have gotten pain, even though we have them sedated with a sedation drip and they cannot obviously self-report. We want to look at, again, those behavioral signs I talked about, like that we find in the FLAC scale. You can use a surrogate, someone else, but you have to be careful because studies have shown that if you use a parent, a spouse, or a caregiver, they may over or underestimate pain. So, here are those other behavioral tools I said that were on page 34 that I have never used. Obviously, I've used the signal communication boards, reading lips, pointing, fingers, pen and paper with mechanical ventilated patients in an ICU setting. But the other two behavioral pain tools I've never used, just the flat scale. So when we talk about pharmacology, they talk about multimodal analgesia, and that is because pain is so complex. We usually don't treat it sometimes with one pill or one approach. We use multiple, 2 or 3 different types of drug classes. We may use a a non-opioid drug class over the counter with an opioid to try to potentiate action. There are various routes your book talks about with pharmacology. Obviously, in the hospital, the 2 most common are oral and IV. We usually go from PCA/IV down to oral quickly. There's really no pain medicines that we give really anymore. Intramuscular, you may give some IM if you work in an ER setting. The person is coming in and leaving, again, quickly sometimes, or in an outpatient urgent care setting. We try to schedule pain medicine around the clock. Dosing are designed to control pain for patients who report it being present for 12 hours or more. So your chronic pain syndromes, whether them be cancerous or non-cancerous. And then a lot of times we have breakthrough medication to break through in addition to what we're giving possibly around the clock. And we are doing a better job with that in the hospital, I will say. The PCA stuff we already covered in the pharm lab. You can read through the slide here and be able to pretty much know what you need. It was very basic and small. I do want to mention that the patient's sedation level is a huge factor in knowing whether or not we can continue using that PCA. Popular pain medications, and I made another pain medication review that's just a Word document. We have non-opioid therapy, the opioid therapy, and then the mixed and partial. And I'm going to pull down and go to that other document if it will let me. So pain medicine review, here are our different routes again. A lot of times oral and IM are the 2 that we are using in the hospital. We also use some transdermal. That's a little bit more frequent. So that with the opioids, we worry about the opioid side effects, respiratory depression, which really is not as big a factor as we make it out to be in undergraduate nursing school. Like I said, I will sometimes sit, I've said this I think in the PCA lecture, I will sometimes sit on a patient's respirations if they're 8 to 10, as long as they are awake or alert, oriented. We also worry about some other side effects, the constipation for sure, nausea, vomiting. So morphine sulfate, if you could compare morphine, Dilaudid, and fentanyl, morphine is strong, Dilaudid is stronger, and fentanyl is the strongest. They make note to that there is almost like a conversion table on page 40 in the 8th edition of Iggy that talks about the differences. But, for it explains to you with morphine that for every 10 milligrams parenterally, it only takes 1.5 milligrams of Dilaudid and 100 micrograms of fentanyl. So you can see that Dilaudid has the generic name that we usually use, hydromorphone, and then fentanyl's other name is Duragesic. Morphine has a lot of other names, especially with oral routes. Roxanol is liquid form. We give a lot of times orally, buccally to hospice patients. We have MS-Contin, OxyContin, Oxy-IR. So with Oxy-IR, you have to know you can crush that one, but any type of Contin, so OxyContin is extended release, MS-Contin is extended release, you cannot crush those. Dilaudid, a lot of times we give that in IV push or in PCA pumps. Fentanyl can be given in IV pumps, like in the form of PCA. We also can give it transdermally. Transdermally is probably the most popular way to give fentanyl. We have to be careful if we have partial doses in the hospital of any types of these opioid drugs, because if you have a partial dose, you have to have a witness waste, and the medication needs to go in the Cactus Smart Sink, which is mounted on the wall in the medication room. So you're wasting the medication with a witnessed person or with a witnessed licensed professional, registered nurse, and they have to actually it's witness waste back into the Omnicell machine, so you have to actually fingerprint back in that someone watched you waste 2 people. Oral pills, we have the hydrocodone in the form of Vicodin. Vicodin has higher levels of Tylenol, and it comes in a fraction. So the hydrocodone is the 5, 7.5, or 10. The 500 milligram is the acetaminophen. So that's why most hospitals have gone to a drug called Norco. Norco is got lower acetaminophen in it. So you still have the 5, 7.5, or 10 version of the hydrocodone, but your Tylenol is only 325. And then we have Vicoprofen, which is hydrocodone mixed with ibuprofen instead of acetaminophen. If you have someone that cannot take acetaminophen, maybe due to reasons where they have hepatotoxic issues. Demerol is not used anymore. Demerol is a opioids to avoid. It was very widely used when I was first a new nurse. Everyone got morphine and Demerol. We gave it IM. We gave it IV push. It has been removed, almost severely restricted, and the reason is it can cause delirium, tremors, myoclonus, seizures. It can affect, in older adults, renal function, elimination. It has no advantages, and so really no place to be used in the hospital. I probably haven't given it, I'm going to say in 12 years, 13, 14 years. The neurotoxic side effects. It's just a drug with too many side effects. The true drug abuse, the abuse drug seekers that used to come into the hospital, they loved Demerol. I had a drug addict tell me one time that it produced like the best euphoric feeling that they could possibly get, Demerol. So, no longer anymore. Your drug abusers, your substance abuse, I should say, abusers can no longer get Demerol, because we just don't give it. Your non-opioids in the form of non-steroidals, acetaminophen. So these are really the 2 that we use. Toradol is used a lot. We give it IV push for 5 days only. It is very good to treat the neuropathic pain, which is that abnormal pain processing. We give it for 5 days, and you do need to check renal function. After that, they can't have it anymore. We also do give the ibuprofen in the hospital. Watch for side effect, ulcers, and GI bleeding. And then you move down to your Tylenol. Your textbook says that ATI says they can give up to 4,000 milligrams. The Adams textbook is only using 3,000 milligrams. This is daily for someone. I can tell you that with the Iggy book, they also mentioned that you can go to the max of 4,000. And I know that SIH is using 4,000 milligrams of Tylenol for a daily max dose. Reversal agent for Tylenol overdose is Mucomist, not nebulized, but to actually drink. We have to open the nebulizer vials and pour it in a cup and they drink it. With adjuvant therapy is listed on page... Where are our adjuvants? I'm pages and pages off out of whack, so I cannot find where I was at. Adjuvants are on page 45. So these are other drug classes besides your over-the-counter and opioid class. So antidepressants, anticonvulsants, anti-anxiety, steroids, and then your book has a small section that talks about they work synergistically. So your antihistamines like Benadryl, Vistaril, and your antiemetic drug class in the form of Phenergan possibly may work to potentiate an opioid. So we sometimes give them together. Well, not in the same syringe, but we give them closely together on the electronic MAR, if that makes any sense. And then there are those 3 drug prototypes that you can look at in the Adams textbook: morphine, Narcan, and aspirin. Did I have Narcan up here that I needed to? So with your opioid drug class, the drug that we would give to reverse that too much would be considered naloxone, and that is also its brand name called Narcan. We usually give it IV push. We usually administer it slowly. The patient becomes more arousable. Really giving too much too fast can cause them to sit up in just extreme severe pain. So going back into the PowerPoint slide, we have then our drug class here. These are our popular non-opioids, opioids, mixed and partial group. I talked about the Demerol and why we don't give it. Here's your Narcan, either in the IV push form, either in the vial at the top or the pre-filled at the bottom. And then we have the Narcan nasal spray that they keep now. Some officers and first responders and things sometimes keep the spray. And the spray is at you can get them at stores like CVS and Walgreens, and they're quite expensive. I think they come in a 3-pack. I think we went over this slide on the Word document handout. These are all terms that you need to be aware of. We talked about morphine, fentanyl, and hydromorphone already. In 2014, Vicodin changed from a Schedule 3 to a Schedule 2, so there are some different regulations now requiring you to see a provider for refills and things like that, all to try to curb that opioid crisis that's brewing now, 2018. Here are your pain reassessments that I already mentioned. You need to just know these. This should be in your pain protocols at most all of the hospitals and urgent care type settings that you will work in as healthcare providers. Methadone is mentioned. It has a very long half-life. There are a lot of methadone clinics to try to help with substance abuse, to help patients try to get off of the other types of opioids. Ultram or tramadol is mentioned as a dual mechanism analgesic. Ultram and Ultram ER are both used for acute and chronic types of pains. Then your intraspinal route is listed on page 42. The intraspinal route, usually by the epidural route, we use morphine, hydromorphone, and fentanyl. With the epidurals, you want to look at the drug alert box down at the bottom on page 42. It talks about assessing your local anesthetic for the ability for them to bend their knees and lift their buttocks off the mattress. And you want to promptly report numbness outside of the surgical site, inability to bear weight, and severe hypotension to the healthcare provider. What is the #1 prescribed pain medication in your clinical facility? My guess is probably morphine or some derivative of morphine, Roxanol, OxyContin, Oxy-IR, MS-Contin. Your opioid side effects are listed in a table on page 43. We use the sedation scale. The sedation scale is listed on page 44. You want the person to be a #1, which is awake and alert. Or a #2, which is slightly drowsy, easy, arousable, which is also an acceptable number. If you are scoring a 3 or a 4, those are both unacceptable. #4, if the patient is no response to verbal and physical stimulation, then you would have to stop the opioid immediately. Sometimes if we give the IV push too fast, we can elicit the nausea and emesis. We use ondansetron for nausea and emesis at SIH. I talked about with the sedation using the end-tidal CO2 monitor that connects to the Alaris pump into the nasal cannula to monitor CO2 levels and respiratory rate. And then constipation. Your doctor may have to treat this with certain drugs that can combat that bad side effect for opioid use, especially for chronic pain. Your adjuvant therapy we already went over. Regional anesthesia. There's a small box on regional anesthesia. They talk about using nerve blocks in a small paragraph. What is the #1 adjuvant prescribed at Celtic Home Healthcare? And this is an adjuvant. It would be the drug Neurontin or gabapentin. It's got multiple indications or uses. It comes in capsules or tablets. Its major side effects, it can cause the angioedema of the face and under the eyes and around the circumoral region around the mouth. Then your book talks about placebo use. Pretty much placebos are unethical. They have both ethical and legal implications. Violates the nurse-patient relationship, deprives the patient of appropriate methods of pain assessment. So using a placebo is deceitful, and you should never administer a placebo to a patient. Non-pharmacological pain management in the form of some physical modalities, occupational physical therapy, aquatherapy, acupuncture, walking, and yoga are some physical modalities. Then we have cutaneous stimulation strategies, the use of hot, cold, pressure, massage, vibration, or a TENS unit. The TENS unit, of course, is a device that delivers these currents through these electrode patches. That's what's in the picture there. And usually the current is regulated by adjusting a dial to the point where the patient feels like the areas like pins and needles are falling asleep. And then we have your cognitive or behavioral strategies in the form of artwork, reading, watching television, diversion, relaxation, those types of things. So that is the pain chapter in a nutshell. You need to read the chapter, know the blue bold terms, look over the yellow boxes, some of the highlighted pink boxes, and make sure you take a look at the the pain medication review sheet. I wanted to just show you, this is the IV over-the-counter Tylenol that we talk about, the glass bottle that you need to vent. If it will load, it's not going to load. My computer is, here it is, Ofirmev IV Tylenol. We give the 1,000 milligrams in 100 milliliters over 15 minutes. This works very, very well for pain in patients, better than an opioid. And then we have the Roxanol that I talked about, and the Roxanol in the hospital should go in the brown oral syringe. Anytime you see a brown oral syringe, that means oral, not parenteral, meaning IV, sub-Q, or IM. And then we have the various looking fentanyl transdermal patches, a 75 or 50 microgram patch that we usually change in a hospital every 72 hours. Of course, when you are applying or removing these patches, you would want to follow the protocol with applying and removing topical medication, including disposing of the patch in the appropriate waste system in the medication room or in the soiled room where it's not going in a trash can. So that's really all I have on the assessment and care of patients with pain, and see you later.